What I'm going to present here is a project that is almost coming to a close, we hope. And it's been done in association with Compass Informatics and ourselves. And it's for the NHS in London, but a particular strand or an arm of that NHS. So just to give you an overview, I suppose at the outset we want to see why it's important to plan for health, and that's why we're here doing this project for the NHS, was that they are very conscious of proper planning for health within the Greater London area. So I want to talk to you about what Hoodoo is. It's not some sort of magic trick. It's a real life entity of the NHS. Understanding the existing model, so there was already an existing model developed that was very Excel based. Talk about the new model, which is now a web-based tool, and then just give an overview and summary of it. So basically, we as either policymakers, planners, health scientists, plan for health, is to bring together plans and strategies to improve health and reduce health inequalities. And if you can imagine, in London, you might have got some sort of flavour for it if you've been watching the Olympics and how that whole city is turned around, but there is huge disadvantaged areas in London. And this is one of the tools they use to overcome particularly the health inequalities. To identify, plan and deliver, again, health infrastructure, which is absolutely key to England and to the Greater London area, this health infrastructure across the whole of the city area. To ensure that development proposals address health issues and impacts. This is even new health development infrastructure being rolled out. And I suppose the key thing is for Hoodoo and for the Hoodoo model, and then for health planning, is to secure development contributions from new developments that are streamlined and fast-tracked into health. And just to explain very quickly the difference between how development contributions work in England compared to here. If you do any planning application here for anything from a new house up to a multi-storey building, you have to make a contribution to the planning authority. This is a development contribution, and they base that on the size of your building, the impact that building is going to have on, say, water, sewage, roads, parks, etc. And then you make this contribution. In Ireland, you pay that to the local authority. It goes into one big pot, and you don't really know where it goes to. You have no idea whether it's going into your parks, into your health, into your schools, into your leisure. You have no idea. Mostly, it just goes into the council's budget, and they have to deal with it as they see fit from above. In England, the way they have it, they have what are called Section 106s. And the Section 106 comes from the Planning Act. And under that Section 106, there's clearly stated where every contribution is calculated and goes to for your development. So if you're saying you want to put in 100 new houses in the city of Hackney, in the Borough Council of Hackney, they calculate exactly what that contribution is, and you can see as a proposed developer where each of those contributions are going. And that money has to go there because it's watched by the Mayor of London, so that's really, really important. They're changing that slightly in that the 106 is based on single developments. They're going towards this SIL, which is a community infrastructure levy, where they're pooling all developments together. And our model had to reflect this, both the single and this pooling. So this is why it's really important to have we've got a really good, accurate tool for the calculation of these contributions. Okay, and just to show you, this is just a mapping we did to show Hoodoo the issues of deprivation and of population and growth in London. This just shows you very, very quickly a quick snapshot of the Greater London area. Greater London area is made up of 33 borough councils, all working together under the Mayor of London. And you can see there the actual health deprivation in there. And there's various indicators, going back to our indicators again, there's various indicators that develop our health deprivation index. But you can see there's very kind of dark purple spots there where there is significant health issues in London. With that, they have significant housing growth, and you can see there's parallels between deprivation and housing growth. And the way housing growth and they do their health or they do their housing projections in London, again, it's very different the way it is here. We have all our local authorities that do what are called housing strategies. In London, this is governed by the Mayor of London. They govern all of the housing planning, and then it's up to the local authorities to actually work within that remit of the Mayor. So where there's brownfield or regeneration occurring. That all feeds into the Mayor of London's plan, and that determines what your housing and population growth can be for 10, 20, 15, 30 years forward. So that kind of just gives you what we're talking about here in the model. What is Hoodoo? Hoodoo was developed in 2004, and it stands for the Healthy Urban Development Unit. And it was a strand, as I said, of the NHS. And they look after and align health planning with the actual growth of population and housing. The aim of it, as it kind of says in the title, is to promote healthy and sustainable communities. Healthy living, sustainable communities from that living. Hoodoo seeks to improve the links between spatial planning and health sectors. As you can imagine, like in many of our sectors in Ireland and across Europe and UK particularly, a lot of the sectors are kind of disparate. We don't really talk to each other. Health doesn't talk to planning. It doesn't talk to infrastructure. It doesn't talk to roads. Under Hoodoo, they have the remit to bring health and planning together, which is really, really good. So they're looking at stuff like population change, development pressures, showed you up there on the maps showing housing growth, environmental constraints, and delivery of healthcare, which is all, that's the bottom line, because you want to deliver healthcare to the communities that need them. So the existing Hoodoo model, since 2004, Hoodoo developed this model, and it effectively is this planning contribution tool. So it calculates the cost, the financial cost that is going to be imposed on the health system because of the new growth that the developers must pay for to assist in that new planning for health. So it's a very evidence-based tool that developers and local authorities can go in and have a robust discussion about. So looking at the existing model, okay, so it's about developing sustainable agendas, enabling full appreciation of health service requirements, resulting in new residential and mixed-use development. And the current web-based model provides a basis for the calculation of costs for the NHS. With the model, what you're looking at is obviously population, but that is translated into housing, and then it's translated into health informatics. So looking at the actual model, the new model is based on the existing structure. So how the model works is the existing model and the new strand of the model. How this works is that you as a developer puts in a new development for 100 units, 100 housing units. What this model is able to calculate, it's the population gain factor. So what it's looking at, it's not the new population that you're bringing, because that population could be taken from an already existing part of your borough council and it's moving to another part. That has no new implications for health. You're still dealing with the exact same population. It's the population gain. So it's the new population that's coming from this new development that's going to have an impact on the existing health service, and how you can plan for that and what impact that is going to be. So we're looking at this planning application. Within that then, when you're actually doing the calculations, it has to bring in 4 strands. Bring in population housing, so looking at the new housing, the take-up rates, this is when people are actually moving into it. So if you imagine, when you build a development, that development doesn't fill up immediately the next day. There's a take-up process that has to be factored into it. With that, there's the population gain factor that I just spoke about. Then there's the household characteristics. What I mean by that is every household has different characteristics. Everything from a single to a partnership to a parents with one child, etc., etc. So every household will have different characteristics, which have to be factored into the model itself. And then you have the outputs from that. From that, then we have the healthcare statistics. So everything from the existing length of stay, average length of stay, occupancy rates, type of actual health problem that you're going to. We get all this from the ONS, from the HES data, what's called the health episode statistics. All this is then fed into the model. From that, then you have spatial requirements in terms of how many additional beds do we actually need. And with that, you have a spatial allocation. For every additional bed, you have to provide an additional space in the hospital. So if our population gain exceeds what we can cater for already, we have to look at additions to the actual health infrastructure itself. And then there's 2 types of additions you can have. You can have the capital cost additions, which is building new infrastructure, either a new hospital, new healthcare service, a new extension to an existing hospital, but then you have the revenue costs. So do we need to provide additional doctors, nurses, healthcare facilitators, etc. So you have both the capital and the revenue, and these are again calculated. So then we produce summary outputs of this to allow then the calculation of what this cost is going to be in terms of both structural and in terms of revenue. And with this is done, every borough council uses this to calculate their costs, the new costs of this new population gain is going to bring on them. They get an output of this, an evidence-based output, and then they go and meet the developer and they discuss then, this is what you have to pay for health in this area for this development to pass through the planning. What we have done in the new model, we've replicated the existing one, which is a single-based development. So you come in with your 100 houses, we can do your calculations. What we've had to do now, because we're moving from this, if you remember what I said at the start, we're moving from this section 106, which is all to do with a single development. What we've had to do now is encapsulate what the new government is bringing in this CIL, which is the community infrastructure level. So it's looking at many different developments in a borough council, and what does that mean? So we've had to look at how we can group a single development into a number of developments. Anything from up to 3, 4, 5 developments within the borough council. These could be done by different proposed developers, different housing agencies or housing authorities that they use that they have in England, but they had to group them together to see what the cumulative impact is. Not only that those first two options are based on where developers come to you and say, we're building these new houses and our population gain, working through your model is going to be X. We have had to add on 2 additional options, where we have housing targets and population targets. Housing targets, as I mentioned earlier, are done by the Mayor of London. They do these housing targets, 10-year housing targets that are reviewed every year. So where they come along and say, okay, in the Greater London area and for our 33 borough councils, we're going to have this housing growth over the next 10 years. So can you tell us what's this impact going to be on health for 10 years' time? Not only with that, the local authorities or the borough councils, they do their own population projections within their own areas for the next 10, 15, 20 years. So we've had to calculate and determine projections for housing and population as well as existing single developments. So the model brings these 3 together in a very integrated manner. Looking then at the geographical reference to this, we have in London, we have, as I said, we have borough councils, and we also have another disadvantage to us, we have these primary care trusts. So we've had to be able to apply this to borough councils, which are 33, and primary care trusts, which are 31. They're effectively the same administrative boundary, except for 2 instances. So we've had to deal with that as well. In summary then, what the new Hoodoo model is about improving the links between and aligning healthcare provision and spatial planning. It's about using geographic and demographic and health information to create these health contributions. What we're doing within the model now is when we roll it out, and there was web-based tool, is we're going to actually put a GIS basis on this. So our new model will allow you to put in a northern and eastern spatial reference. So when we roll it out then in the next stage, we can actually base this all on GIS as well. So the local authority users can see exactly where their new development, their new growth, their new housing projections are occurring. And finally, which is really important for us, is that there's significant potential and justification to adapt and implement this model that we're rolling out here across many jurisdictions, in borough councils and city councils across many EU member states. And we're actually in the process of talking to our Minister for Health on this at the moment about how we can roll this out. Thank you very much for your time and attention.